continue to restart again today. I hope you'll be able to. Can you hear me?
Yes, doctor.
Yes. Okay. Fine. So yesterday of course, I spoke for the full session, but unfortunately there was discontinuation of signals, so I had to redo it today. That's how it's happening. But let me see whether I can go a little faster so that the schedule is not affected and everybody is on board as it's meant to be. So looking at is that basically we know that IV fluid is a concern actually, right? Why it's concerned? Every patient who comes to hospital, especially if they are very sick, they're going to require IV fluids for various requirements, including just fluid requirement, nutrition, medications. For all the reasons, they require fluids. So I'm going to speak on if a patient comes with COVID issues, what is the situation? Either they hydration, or they come with hypovolemic shock, or they may have cardiogenic shock with myocarditis as a manifestation in a critically ill patient, or sometimes they can be a post-COVID like multi-system syndrome of children, where they can present a significant amount of shock, which could be cardiac involvement, or otherwise also there could be toxic shock syndrome like presentation also sometime post-COVID situation. These are the usual scenarios they require to start. If you remember, COVID asymptomatic or it may be mild disease, and they don't require to be in the hospital, and most of the time it's managed in the ward. I just remember over the last few weeks, the cases have been come down so significantly. There is a lot of relaxation with respect to guidelines and restrictions. And we know that even the theatres have been allowed to have full strength in Bangalore and Karnataka actually. And we know that today's case, possibly it's about 22,000 something cases have been reported from across the country. It's been quite significant what it was there. But we also have a concern that today it's also that the director of the All India Institute of Medical Sciences suggested that pandemic is not yet over, one has to be careful. Why I'm telling, because now just an hour back I happened to see a patient, about 4-month-old child come with COVID positive. Unexpected, patient comes with some kind of respiratory symptom, seasonal flu kind of infection. We manage them. So this patient had some kind of respiratory difficulty, required intubation, admission. We had to do as a requirement to do COVID test. It has come positive. So we are shifting the patient to COVID ward for the management. It means to say, as the director of AIIMS suggested, COVID is not yet over. We are going to see cases. And we know that we already relaxed a lot of the restrictions, and we are much more relaxed. Maybe we are less careful with respect to the precautions, including social distancing, mask and other things may predispose to spreading of the infection next 2 to 3 months actually. So in this background, we expect possibly to see some cases, if not more, pediatric patient requiring hospital administration. Fluid is going to be an important requirement. Let us see what exactly is usually followed actually. Normally, patient comes with a hospital for whatever reason requires maintenance fluid. The practice is to use isolate P. That's the standard practice across wherever you go actually. If patient comes with some kind of dehydration or resuscitation requirement, normally we use either normal saline or ringalactone. That's also, I'm sure most of you are well aware of it actually. But it's also important to remember when we calculate fluids most of the time, we do not really look at what is the electrolyte requirement. We just go ahead with whatever the way fluid is calculated. So that could pose a risk to the patient. So it's very important when we are calculating fluids, we also look at possible calculation for the electrolytes, especially if you are going to use maintenance fluid. So this is an interesting slide. Normally, if a newborn baby has been looked at, 80% of the weight is basically water in the body. So it means if a child is about the 3 kilos, almost 2.6 kilos weight is all about water than anything else. So that's the amount of water in the newborn. Yeah, it comes to 7% 1 year, and then drops to 60% by 12 years, and remains to be around 60% in adulthood actually. This information is very important with respect to understand for various calculations. We use formula called 0.6 into body weight. This 0.6 into body weight comes from 60% of the body's water. This is what is reflected. So this is the formula everywhere used for calculating hyponatremia, and many other things. This is the calculation. So this is the fluid components. Basically, there is extracellular fluid, intracellular fluid, and interstitial fluid. If you look at extracellular fluid, is more often consisting of sodium, chloride, and some extent bicarbonate. You could see there is hardly potassium in the extracellular fluid. On the contrary, in the intracellular volume is basically filled with potassium, almost about 160 milliequivalents compared to just 4 milliequivalents. Look at sodium, the very negligible amount of sodium, chloride, and bicarbonate. So when we look at fluids as a possibility, when we talk about sodium, we are talking about more of extracellular fluid. When we talk about intracellular fluid, it's more of potassium actually. So when we talk about what fluid is required, this is basically derived from by Holiday and Sagar in 1950s, and they found out that for each 100 calories, we require approximately 100 ml of water for the metabolism. It means to say, for the metabolism of 1 calorie actually require 1 ml of fluid. So let's see how it goes actually. Normally, we lose about 50 ml per 100 calories of insensible water loss in the form of sweating and other signs. We lose about 66.7 ml through urinary losses. So it comes to close to about 116.6 ml, approximately 117 ml per 100 kilocalories of fluid. That's the requirement per day. But you also remember, body during the process of metabolism also produces about 16.7 or approximately 17 ml of fluid. So that's how it comes to that. If you remove this 17 ml of fluid from the requirement, it comes to about 100 ml per 100 kilocalories. That's how this calculation comes, like 100 kilocalories require about 100 ml of fluid. So this was basically done in a measurement with normal breastfed babies, good-looking, well-laid babies. Actually, there is a concern here to look at and accept the recommendation. Let's see if we go as we go further. So what it says, always a Sagar formula. As we discussed now, the data expenditure can be determined by the formula of the body weight. So for up to 10 kilos, you give approximately about 100 kilocalories per kg per day. That's the requirement. After 10 kilos, you add up, for that up to 10 kilos, it becomes 1000 kilocalories. Then subsequent for every kilo, you're going to add up 50 kilocalories per kg per day. So you go up to 20 kilos. By 20 kilos, it becomes 1500 kilocalories. Subsequently, you're going to add up 20 kilocalories per kg per day. So this is how we are going to calculate the calorie expenditure and requirement in the children actually. And we know that every kilocalories require about ml of fluid, 1 kilocalorie require 1 ml of fluid. The same thing is translated into fluid requirement. So up to 10 kilos, you are going to follow 100 ml per kg of fluid per day. And after that, you are going to add up 50 ml per kg for the remaining kgs. It becomes about 1500 ml per 20 kilos. Then subsequently, you are going to add up 20 ml per kg for remaining whatever the weight you are going to calculate. So this is how the formula is implemented. So what is here is to understand, while calculating fluid, also keep in mind that you're supposed to administer sodium and potassium. We require approximately about 3 milliequivalents of sodium and 2 milliequivalents of potassium has to be supplemented in the maintenance fluid. So let us look at how it goes for a 10 kilo child. So 100 ml per kilo, it requires about 1000 ml of fluid per day. If you add up 3 milliequivalents per kg of sodium, it becomes 30 milliequivalent sodium is required. Similarly, if you add up 2 milliequivalents per kg of potassium, the 10 kilo child requires about 20 milliequivalents of potassium. So this is the requirement for a day for a 10 kilo child. So approximately the fluid which matches this requirement is isolate P, or something similar to N/6 into 5% dextrose saline. Actually, that's the standard fluid which matches this requirement that we're going to see in one more slide in subsequent slide. So this is where isolate P has been considered as a choice of fluid in the fluidic requirement in children. It meets the fluid requirement. It also meets approximately the sodium requirement and potassium requirement. That's how isolate P has become more. It's been accepted as a policy, but for quite some time, for many decades, that isolate P is considered a good choice. But you know that after this has been followed, at some point of time, people also realized that the case, and then started looking at the implications of using isolate P as a fluid choice in the pediatric patients. Let's take a moment. Can you hear me? Hello.
Yes, sir. Go ahead.
Okay, there is some college I wanted to
Yeah, doctor. Yeah, doctor.
signal is disconnected. Okay. So look at the fluids that's normally used. You use normal saline or use dextrose. You can use half normal saline, one-third normal saline, isolate P, ringer lactate. These are the fluid we normally use in pediatrics. If you look at this slide, take a minute to look at this slides. If you take dextrose, either 5 or 10% dextrose, they both contain either sodium or potassium. That's an important point. Similarly, if you look at normal saline, it contains about 154 per milliequivalents of potassium for about liter. Half normal saline comes off of it about 77 milliequivalents. One-third normal saline contains about 57 milliequivalents. Look at isolate P with 5% dextrose, it contains only 25 milliequivalents of potassium. And look at ringer lactate, it's about 130 milliequivalents of potassium. So when looking at all these things, what we understand is that normal saline contains about 154 milliequivalents of potassium. It's almost similar to the body's composition, approximately about 150 milliequivalents. That's where normal saline fluid composition is almost physiological to the body's requirement. So when you administer a normal saline, possibly the sodium requirement and the matching happens so well that the risk of complications like hyponatremia, or maybe even a little risk of hypernatremia, is very negligible in this patient. On the contrary, if you use half normal saline, there is a significant risk here with half of the sodium is not there. It comes down further with one-third saline. You look at isolate P, it's almost 1/6 of the sodium requirement. Basically, it means when you use isolate P as a fluid for the maintenance in children, basically you are straight away having 1/5 of the requirements, almost about 125 milliequivalent less sodium is administered in this patient. So that predisposed to the development of hyponatremia. It means to say, in all patients who require isolate P, especially in situation of critical care or high dependency area, if you use isolate P, you are going to risk the patient for hyponatremia. And of course, you know that looking at this type of fluids here, actually, the ringer lactate and normal saline, they are isotonic fluids, means the tonicity is similar to the body's requirement and the matches. On the contrary, the half normal hyponatremic. Similarly, isolate P is also basically, except normal saline to some extent ringer lactate, all other three fluids possibly we're using as a maintenance at various situations, they're all hypotonic fluid. So it means to say when you use these fluids, the tonicity of fluid is significantly affected because of sodium also, and definitely is going to affect fluid homeostasis, and it's also going to affect the sodium homeostasis in the body actually. So this is where we understand that when we choose fluids, the recommendations in the critical care setup goes that you choose an isotonic fluid which has sodium quite matching to the body. So normal saline fits well into that picture, and then of course it comes ringer lactate. That's the basis for looking at that while we need to look at fluids while choosing in pediatric patients. So then, as I told, actually, is it an appropriate fluid? From 1950s onward, it's been a popular choice of fluid across the world where it's been synonymous with fluid therapy in the pediatric population. Isolate P is as good as telling that give fluid to the patient. So the question comes here, is it really the right choice of fluid in the pediatric patient? That's the question. So maybe as a section on that, to the hospital for a critical illness action, there is a possibility or a predisposition for release of excessive ADH secretion. It's called syndrome of inappropriate increase in production of ADH actually, SIADH. So basically every critical care comes to the hospital, you presume is a risk for developing SIADH. That's a background you must look at how to use fluids. It could happen as a result of physiological stimulus, maybe hyperosmolarity to fluids, or it may happen due to physiological, non-physiological stimulus like pain, post-operative, anxiety, nausea, drugs, and all these things result in the patient having inability to excrete solid-free water, and that's what happens in patient with SIADH. So it means to say, Compared to patient who are stable, stays in the ward, the patient who comes to critical care illness has a significant risk of developing SIADH, where you have to be careful about fluid. So this is what would happen. There is a concern about free water excretion in this patient. There is an hyponatremia. There is a concern with sodium. There is a concern with free water. So let us look at this child, a 3-month-old child admitted to the ICU with Streptococcus pneumococcus positive, Streptococcus pneumonia positive, CSF culture positive thing, possibly consistent with CNS infection. This child found to develop a reduced urine output less than 1 mm, so approximately the child will be able to have oliguria after admission. Actually. Then the test suggested that when somebody has got oliguria, you start looking at, like especially critically illness patient, you start looking at why patient has got oliguria. So you start looking at different conditions further. It could be pre-renal, where there is a reduced circulation to the kidney, resulting in the risk of pre-renal injury, like diminished volume dysfunction, vasodilatation, hypertension. In all this patient, effective blood circulation doesn't happen, predisposed to the renal injury. It could be post-renal with some kind of obstruction. It's much less common. And of course, it's more often due to renal causes like acute tubular necrosis, or it could also be looked at as possibly the child is at risk of developing acute renal injury. That's what is the situation in this patient actually. So these are actually, and you also keep it in mind, there could be a possibility of SIADH in this patient. So in this patient, the study suggested reports like this. There is a sodium is low. Look at the osmolarity at 265 milliosmolar per kg, and you also look at urinary studies. There is a specific rapid 1.05, sodium at 58, fractional extinction at 2.4, and osmolarity at 900 milliosmolar. Actually, practically all sodium-related and urine osmolarity and specific related parameters are abnormal in this patient. So, what are the abnormalities you can see in this patient? There is an hyponatremia at 126. There is an oliguria. There is inappropriately concentrated urine in this patient. So when you say inappropriately concentrated urine, that's the SIADH. It could happen on all these causes. Either it could be infection, trauma, metabolic conditions like diabetic ketoacidosis, medication, and it could be CNS infection. Even ventilation and stress related to pain and fever could also predispose to development of this problem in this patient actually. So again, the question comes here: is it really inappropriate syndrome? Not necessarily in every cases. Like in case of pneumonia and bronchitis, possibly inappropriate because the response is inappropriate in this patient. But other conditions like an hypertonicity, life-threatening hypertension, and raised ICP, it's exactly a response required for the body to respond to the requirement. And this also hyponatremia and concentrated urine, where you find there is elevated specific gravity, inappropriate high urine osmolarity, and you find normal or high sodium excretion in this patient. So they can present with symptomatic presentation like nausea, vomiting, headache, lethargy, weakness. They could throw seizures, but what is important to remember, they could develop significant risk of hyponatremic encephalopathy, and that could be predisposed to certain amount of concern in the management. They could also slip into coma. So practically when patient goes through this amount of neurological deterioration, there is a significant risk of neurological brain injury in this patient because of sodium related issue. So how do you manage this patient? You restrict fluid, closely monitor sodium, and possibly you need to keep a close watch on the weights also. So let us look at, coming back to the same slide, case actually, patient was admitted when started on isolate P. After a few hours, patient through convulsions and did not respond to lorazepam and phosphorate and sodium. And they looked at the causes, various causes can be considered. It could be an hyponatremia worsening from 126 downwards, or it could be an intracranial event, or it could be meningitis, it could be other electrolyte disturbance, it could be because of medication, or it could be hypertension. All these things could be considered as a etiology of seizures in this patient actually. So what kind of investigation you ordered in this patient? Maybe you can think for a moment. If you consider possible hyponatremia or a CNS infection, or you consider electrolyte disturbance, what kind of investigation you are going to ask? As you could look at that, basically, if electrolyte disturbance is one of the considered things you are going to look at, that actually in those patients, we're going to ask for electrolyte studies actually, right? And you also know that you are considering one of the possibility as a meningitis or intercurrent, you may consider doing imaging and other studies. So these are the things you are going to consider actually. So we know that in the background of an hyponatremia in this patient, you look at what to ask for in this patient. So you see that the sodium came as 177. So obviously sodium has been the reason for the problem in this patient. There is a significant symptomatic hyponatremia in this patient causing seizures in this patient. So this is an interesting slide actually, from 126 going to 177. That's what happens when you put the patient on hypotonic fluid like isolate P. The sodium has been brought down from a reasonably on the higher side of low range from 126 to 117, predisposed to significant risk of symptoms and also brain injury. What has been identified over a period of time, many decades of study, the last few decades, they found that whatever you pick up as an hyponatremia, iatrogenic hyponatremia, is the tip of the iceberg. Most of the time, you end up not picking up them. What does it mean? Most of the time, patient managed with isolate P ward and some other cases, they go unnoticed and possibly they suffer from the problem, or they may just escape with some amount of disturbance and they may not be identified. So only in patients who are admitted in the critical care area or emergencies where we monitor sodium closely, you are going to keep monitoring the sodium. That's how we pick up sodium in this patient. So this has been found that the people identify from research that basically iatrogenic hyponatremia is a significant concern in the critically ill patients with hypotonic fluids, and they have documented the risk of death and significant neurological injury. And it's been also been found that when patients have been given fluid for even simple problems like a dental extraction and common minor procedures, development of hyponatremia problem with sodium actually. So what did they do? Few countries have rather banned using isolate P as a fluid of choice. They have been taken off from themselves actually with a clear warning that if somebody wants to use isolate P, they must justify with a written request that why they're supposed to use, and they must restrict using it only for the required purpose. So practically, some of the places in the countries where the fluid changes have been happened, they don't keep isolate P as a easily available fluid in the rack actually. So then what is the right choice of fluid? If you have a stable patient or a critical patient, you can think about. So in this background, when we say pediatric COVID patient coming to the hospital, we believe most of the time they may be critically ill, require fluid. The ideal choice of fluid is supposed to be an isotonic fluid that's in the form of normal saline or ringa lactate. That's what you're going to use, either normal saline, normal ringa lactate. Even DNS should be a safe choice in these patients. So what is important to remember, when you use either of these patient fluids, practically they don't contain potassium, as we discussed earlier. You also need to take into consideration the electrolyte requirements. You add up potassium to this fluid and then as a maintenance fluid. In a stable patient in the ward, if you are comfortable using, you can still use isotonic fluid, normal saline, ringa lactate, or DNS with potassium supplementation, or you can consider using isolate P as a possibility, as a matter of fact of practice rather than the trend and the need actually. So here also you can use the same fluid in the stable patient in the ward. Maybe you can also use DNS also. So what does it say? If you have a critically ill patient, isolate P doesn't appear to be a right choice of fluid. It's not been recommended to use, which could be significantly detrimental to the patient care outcome and the death also in this patient. In stable patient, maybe it can be used, but with confidence of using isotonic fluids with adequate putting up of electrolytes, you can use either normal saline or ringa lactate or even DNS. So that's about fluid. Look at this composition actually. Isolate P is telling that basically they contain about approximately 23 milliequivalents. They contain 20 milliequivalents of potassium. And of course, 5% dextrose remaining are comes as a part of it. So this thing is obviously suggestive of hyponatric fluid compared to the normal saline, which contains 154 milliequivalents. It contains 130 milliequivalents in ringa lactate. That's how you go with that. Then whatever dextrose normal saline, I told basically another choice we can use it like they also contain approximately about 154 milliequivalent sodium, similar amount of chloride. They contain some amount of dextrose also. So dextrose normal saline, this composition, it become a hyperosmolar fluid. So resulting in the risk of hyperosmolarity related problem in this patient. One has to be careful about using this patient. So basically, when you're looking at giving isotonic fluid, you are going to use basically normal saline or ringer lactate. So this is a table about how to choose easy table readily available table for looking at different ways, what is the amount of fluid required, how much you are going to run if you are going to use adult drip and a pediatric. Same thing is here. Maybe you can take a screenshot here that could be helpful to you. Just
Doctor, you're on the mute.
yeah. Anything? Okay. So then coming to the choice of fluid, you also look at there are two classifications: crystalloid fluid and colloids. Actually, when you say fluid of choice, it's basically crystalloids are the fluid of choice. That means to basically normal saline ringer lactate because they are easily available. Not significantly less side effects, and it's very cheap. You don't ask for ringer lactate. There are availability to pharmacy. That's where they remains to be the safest bet as far as choosing the fluid actually. When you use them, they are readily distributed in the spaces, intravascular interstitial spaces. This stays for a transient time in the interstitial space. You can give large volume of fluid, and then it's going to be much safer, and it's been removed from the body much faster. That's how the benefit of crystalloids. So when we say use fluids, use crystalloids, crystalloids, crystalloids. Then question comes about colloids. We refer to basically using albumin, starch, gelatins, and others where you thought of using in only special situations. Normally not recommended as a first line of fluid for anything in the critical care unit, but however certain situations like burns, non-responding shock, including dengue fever, septic shock, people continue to use it. And as I told, like holiday cigar formula, after the formula can people looked at various ways and literature and found out that it's not been safe. Similarly, after it's been accepted that crystalloids are the colloids are the ideal choice of fluid, people studies are using colloids also, and it's been found to be reasonably safe. That's the current available evidence suggesting that wherever the possibility exists, one can safely use colloids also. But as we understand, for the maintenance to go with crystalloids only. So coming to the inotropes, actually, second part of the study, we know that we are all using dopamine and dopamine, and we also know to some extent about norepinephrine and epinephrine also. And the new addition to that is milrinone. So basically, we know that over a period of last many decades, it's not just dopamine and dopamine. Now we are comfortable using epinephrine and non-epinephrine. It's much more easy to use inotropes with a better quality of care and outcome in the critical unit setup actually. So all these drugs are used when there is a shock actually, either refractory shock, distributive shock, cardiogenic shock, or things like that actually. Mean to say, you use inotropes when there is a need for hemodynamic stability and the patient has got shock. To bring it up, you require to use inotropic supports. And dopamine, dopamine is recommended in those areas from 2 to 20 mics, but normally we use about anywhere between 5 to 10 or 15. Very rarely we go up to 20. And epinephrine and norepinephrine, the dose of 0.1 to 1 micrograms per kg as an infusion. So practically, all drugs, inotropes drugs have been used as an infusion actually. And you look at next thing, they can be diluted in normal saline, DNase 10% and 5% dextrose. One important issue with respect to administration of inotropes that practically recommends that all has to be given to the same time. But we know that in our countries, possibly most of the developing countries, putting central line skill is a luxury, and most of the time it's not very easy to do it. And again, it's also related to non-availability of the lines for putting, because finance is a big issue. Basically, we end up using peripheral vein. So the question comes here, should we use it through the peripheral vein? That's a multi-dollar question actually. But what has been found in the last two recommendations from WHO on the dengue fever management and surveillance sepsis campaign managed that possibly in an early stage of management of this patient, before you could able to establish a central line, you can use dopamine, obviously, in small doses through the peripheral line to stabilize the patient. That amount of acceptance has been given. Now, no more you need to worry about starting immediately. But as the patient stabilizes, better to put some central line and shift over to the same thing as I told about the doses for dopamine, dobutamine, epinephrine, and norepinephrine. So how do you choose these drugs actually? So when you see a patient with shock, you have either a cold shock or a warm shock. What does it mean, warm shock? When patient comes in the emergency or a critical area, patient is in shock, like patient can have hypertension or a borderline BP where the extremities look warm, pink, and it look quite bounding pulses. It's basically seen in situations like septic shock, like that actually. Cold shock is basically where the patient comes in a very bad shock where the extremities are cold, pulses are not palpable, both central and peripheral, recordable, that's a cold shock. So normally when a patient comes with a shock, if a septic shock, it comes in the early stage, it can be warm, but in the later stage, that also becomes cold shock. So when you see a patient with cold shock, you are going to use either epinephrine or dopamine. Earlier, people used to follow dopamine, but of late it's been found that in this patient, practically there's no reason and no worth of using dopamine in these patients. The recommended choice of inotropin management of cold shock is epinephrine. In case of warm shock, you can start with norepinephrine because the actions of the norepinephrine helps in maintaining the perfusion and hemodynamic stability and BP in a warm shock. That's how norepinephrine comes in this patient. But in these patients, require a lot of pumping and of course, systemic activity, sympathetic activity, you require epinephrine in a cold shock. Dobutamine is one of the drugs basically you use as an add-on drug to either of the situation when you possibly suspect there is a cardiac dysfunction or a cardiogenic shock. That's how dobutamine comes into picture. Practically, you don't use dobutamine as a isolated standalone medication in the management. It comes at some point of time either with any of those things or the patient who has got significant cardiac dysfunction, you're going to add up dobutamine actually. So in short, basically, if you have a patient with COVID-19 who comes to the hospital, you need to make a choice with respect to the fluid. As we discussed till now, Holiday Singer formula suggesting the dosage and the way it's supposed to be given. And the thinking was from Isolate P, and the Isolate P is not been a great choice of fluid in the patient. So basically, if you have a sick patient, you choose either normal saline, ringer-lactate, or a DNS. Actually, in a stable patient, you can use either normal saline, DNS, or maybe you can still use Isolate P, but monitor the sodium quite regularly. If patient has got a cold shock, we are going to use epinephrine. If you have a difficulty in procuring or non-availability of epinephrine, you can still go with dopamine pending availability of epinephrine. Whenever it's available, shift over to epinephrine. That's a much better choice. If you have a patient with warm shock, you are going to use norepinephrine. So this is how we are going to choose. And wherever there is a cardiac dysfunction and shock, we are going to use dobutamine. If required, you are going to add even milrinone to this patient. This is how you are going to decide about fluids and electrolytes in this patient. I stop here for sharing my talk today. Thank you so much.
Thank you, Doctor.
Yeah, please. If any questions, I will take it up.
Sir, there is a question, sir.
Yeah.
Dr. Ratna has asked, why has Isolate P is given as DNS seems to be more optimal?
So basically, Isolate P was, as I told in the earlier slides, when they calculated the requirement of fluid in the children, they could match that fluid requirement with the components of the Isolate P. As I told already, for a 10 kilo chain, it requires about 100 ml per kg of fluid. And then, of course, it requires about 1000 ml of fluids that can be easily calculated. You supplement about 3 milliequivalents of sodium per kg per day. So this gives about 20 to 25 milliequivalents, matches again. Similarly, you need to give a supplement about 2 milliequivalents of potassium at 20 milliequivalents. That's also available in Isolate P. That's how Isolate P has been the chosen fluid of choice in this patient. But what I discussed with you now, it's an hypotonic fluid. Hypotonicity and hyponatremia is a significant risk for the development of the complication, and that's where the things have been looked at differently and new recommendation have come. But I would also like to point at this point of time, final thing is not being heard about fluids. Still now there is a concern about some people choosing normal saline, ringer-lactate, some people choosing DNS. The concern and practices still varies, but you choose either normal saline, ringer-lactate, or DNS, either way it's fine actually. Practically, if you ask me, DNS is concerned with hyperosmolarity, especially if you are using it in patients like meningitis or CNS infection. Not a great choice to use, but maybe in other patients where you have concern about giving some amount of glucose, it could be a reasonably good choice.
Okay, sir. Dr. Ratna, I think that answers your questions. That is all, sir. As of now, that was the only question. Thank you so much, sir.
Thank you so much. Thank you.
Thank you, sir.
Thank you, Doctor. So I now hand over to Dr. Inotropes.
Yeah. Good evening to all. Is my screen visible, admin?
Yeah, Doctor.
My voice is audible, no? No issue.
Yeah, Doctor. It's fine.
Okay. Thank you. Okay. Once again, I thank Step 1 for providing this opportunity. Definitely, this is one of the important topic which, as a general practitioner and as a pediatrician, one should know in this COVID era. It appears that now, though we are saying, our previous speakers have mentioned that the COVID in pediatrics, most of the time it will be asymptomatic, and even if it comes, it is majority time mild to moderate. Very few children require the severe disease management. Now, unlike this one, this entity, multisystem inflammatory syndrome, especially which appeared in April month of 2020, just started to have a big epidemic in the Western world, where most of the adults were affected with the severe COVID. Some of the pediatricians, when they are noticing that there are less number of COVID cases in children, they noticed some cases which were presenting with some odd skin manifestations and suddenly presenting with some cardiogenic shock. And ultimately, then they have investigated, they found that it was related to, not related to per se directly COVID, but it is related to post-COVID event, maybe because of some immunological reaction. And since then, all over the world, same cases have been reported, and almost 160 countries have been reported that this condition has been there in their country. And ever since that, it has been one of the differential diagnoses when we are managing any child, specifically in India, when we see a child coming with a history of fever for a certain duration, definitely we have to keep one of the DD. But remember, it is a diagnosis of exclusion unless we exclude other common tropical infection in our country, especially in this time where we are having so many respiratory infections, which are very common in every year. We need to rule out those common conditions first, and then only we need to consider this one. So in my next talk, what I'm going to cover is what is this multisystem inflammatory syndrome in children, and what is the importance, which I have already told some part, and how we need to make a diagnosis. That's the most important question, which we will address that one. And then how we need to investigate and manage these children once we make a diagnosis of MIS-C. So that's all. In next 15 to 20 minutes, I am going to talk. Now, the World Health Organization has come out with a definite criteria to make a diagnosis of multisystem inflammatory syndrome. Now, according to this, this is basically a 5, what we can say that 5 points, most important one, like the first one is fever, which is a must when we want to make a diagnosis of a multisystem inflammatory syndrome. The second one is the most important, the elevated inflammatory markers. Like we're going to discuss all those inflammatory markers in the next slide. And then when they present with the fever, with the raised inflammatory markers, these children should have at least 2 or more organs involvement. It's not just single organ, it is 2 or more organs should be there. And then more importantly, we should have evidence of exposure to COVID-19 in the form either RT-PCR should be positive or IgM or IgG, whatever serology, or even to the extent that if just have a history of contact with the exposed person, that itself will tell that probably we are dealing with a case of multisystem inflammatory syndrome. As I told in the earlier slide, that it is more important that we need to exclude the common tropical infection before we make a diagnosis of the multisystem inflammatory syndrome. Now coming to the important slide of this one, what are the cardinal? When we say that if a child comes with the fever, how I should make a diagnosis of, or when I should consider that there is a possibility of multisystem inflammatory syndrome. Now the most cardinal feature, as I highlighted it, fever is a must. And now the WHO has given that it should be more than 3 days duration. Though the updating is going on, there might be in the coming days, maybe coming with, if any fever more than 24 hours may be considered, but at present it is more than 3 days we should consider. Along with that, there should be cardinal features. What are the cardinal features? The most common organs involved in this system. The most common organ involved is the cardia, which will present with cardiac dysfunction, which will be manifested as either congestive cardiac failure or like a myocarditis feature. Then second most important the system which they can present with this is GI system. And then the third one is they can present with the other manifestations, skin manifestations, probably mimicking like a Kawasaki disease. We call typically as not Kawasaki, it is incomplete Kawasaki, because if you see Kawasaki disease, it is all 5 cardinal features should be there. In most of these conditions, we don't see all the 5 features. That's why it is being called as incomplete Kawasaki, and it is probably related to COVID-19 mechanism. And of late, we are also seeing that there are other systems involved, like neurological manifestation. Most of the time we are seeing, especially some reports have now come recently that most of them have come in their hospital with a meningeal signs, meningitis, convulsion. So this could be one of the way it can manifest as multisystem inflammatory syndrome. But unlike adults, where we have seen that it is the respiratory system where they are presenting, here in pediatrics, we have seen less number. Though it is not ruled out completely, there are manifestations, but they are less likely in children. So these are the important clinical features. When any child comes with these features, we need to keep our differential diagnosis as one is multisystem inflammatory syndrome. Just to highlight why it is occurring in this COVID era is probably again the same mechanism which has been explained with the Kawasaki disease. It is hyperimmune response. We can consider this as probably because of innate immunity, or it is because of adaptive immunity changes. Because of these, it can be an exaggerated response which will result in various organ damage, and then clinically they are manifesting with those organs which have been damaged. Now, it is the better slide to explain what are the clinical manifestations and when we need to suspect. The first one, as I said, it is fever most important, followed by the incomplete Kawasaki disease. In incomplete Kawasaki, we see that most of the time it is conjunctivitis, very prominent, but here it is non-purulent conjunctivitis, which is more important. Then lymphadenopathy, stomatitis, and sometimes those features of Kawasaki like extremity swelling, which is typically will be there. And then the exfoliation of the skin over the palms and soles. So these are features they can present. But what I said is the most common organ involved in multisystem is cardia, which can present with myocarditis, or they can present with the cardiogenic shock or the congestive cardiac failure. The next system which will present with this, again, I am stressing it is GI. In our setups, we have seen more number of cases which can present with any other diarrheal disease like nausea, vomiting, and abdominal pain. So these are there. Apart from that, we are also having children presenting with the renal system involvement, which can present with the hyponatremia and renal failure, which is bit little late. But the point which I wanted to stress here is the respiratory system. Generally, in adults, that is the most terrific thing which we have seen in first and second wave. This respiratory system is less likely affected in pediatric COVID, as well as in the multisystem inflammatory syndrome also. Then they can also present with thrombocytopenia, and sometimes they can present with meningeal signs. More importantly, the second point which I stressed in the diagnosis, it is the inflammatory markers. The inflammatory markers are simple. like our ESR, which has been old one. And now every lab is having CRP, which is most important one when we need to consider MIS-C. And then other parameters, including the ferritin, LDH, interleukin, all these, especially procalcitonin. Among all these, the most important one, which we stress, is the most important one, CRP, which I am going to highlight again in my next slide. So these are the various clinical manifestations these children with MIS-C will come. So finally, to summarize, when to make a diagnosis is any child less than 18 years, if they come with a history of fever for more than 3 days, that's the most important one. If along with the fever, if there is any having 2 or more organ involvement in the form, if they are having incomplete Kawasaki features, or if they are presenting with shock, or if they are presenting cardiac manifestation, or some coagulopathy feature, and especially in our setup, what we have seen is GI. Any of these 2 parameters are involved, we can consider as possibility of the MIS-C. Along with that, we should have always raised inflammatory markers, especially C-reactive protein. I will highlight it is more than 40 we consider as the probability of the MIS-C will be quite high. In some of the institute like us, we take it definitely high probability if it is more than 90. And apart from that, very important thing what I stressed is before we make a diagnosis of MIS-C, we need to rule out the tropical infections, especially whatever we are having. Now, this is a season where we see dengue, chikungunya, rickettsia, very common, even including enteric fever. We need to rule out all these conditions before we make a final diagnosis of MIS-C. Along with that, we need to have the exposure to COVID. That should be there either in the form of serology or in the form of RT-PCR or just having an exposure to COVID-19. If all these 5 features fit, then we'll make a diagnosis of MIS-C. Now, just briefly, I will highlight the pathogens, why we are seeing nowadays, and why we need to keep this differential diagnosis is in pediatric, as we said that though many children are exposed to COVID-19, most of them are asymptomatic. That is the first stage what is being seen. They have been exposed, but they are not having the clinical manifestation. Even though they are exposed, the pulmonary manifestations which may not be manifested, but they are harboring the virus. But among these harbored children, not all will go for the MIS-C. Only few children will be going for the MIS-C. Why it is so? Probably it is because of some genetic susceptibility what is being seen. There are many other risk factors which still under studies, but the most significant one, what is being noticed now, whatever studies have shown that it is genetic susceptibility in those children, they can go for the MIS-C. So once they harbor, there is a chance that these antigens, what we call it as super antigen, they may activate these macrophage system. And in turn, these macrophages, once they are activated, they release helper T cells. And once these helper cells are released, they will induce lots of these interleukins into the system, like TNF-beta, interleukin 6, 12, 1B, 23. All these will suddenly release and cause cytokine storm, and which results in the organ damage and various manifestation, which we call it as hyperimmune response. Notably, you just see that the other side in the figure. It is most important that virus directly will not cause MIS-C. Most of the studies, it has been proved that it is the post-COVID event which is causing the MIS-C. Similar to the helper cells, once it is activated, even B cells are also released and they can produce antibodies. They can also again cause antigen-antibody reaction and results in hyperimmune response. So both the way T and B cells can cause damage because of activation of the macrophage. This is what is being explained so far, and it is the most accepted mechanism for why we are getting more number of MIS-C in children in the era of post-COVID events. This is again a slide to just highlight about the innate immunity and adaptive immunity. Both will be affected in MIS-C, causing the various organ damage. And more importantly, we have seen in our clinical practice that some of these MIS-C will present with mild cases and some will present with the severe cases. Why it is so? The probable mechanism is in mild disease, if there is an early interferon response and which will decrease immediately, and there is a rapid clearance of viruses, which results in less inflammation and less severe disease. Whereas in severe disease, what we see is probably it is the interferon response is delayed, and so also the viral clearance, which results in large amount of inflammation, which can cause the damage. That's how we are seeing various forms of the various patterns of MIS-C in our children. So ultimately, to summarize, what is the most important thing is we see MIS-C not in the peak of COVID. It is generally after say 2 to 6 weeks following the COVID peaks. So that's the common, that's how it is being explained why we are seeing more of these MIS-C after the peak of COVID events. And most important thing is RT-PCR, majority time it will be negative. It is serology which is going to be positive in this. And the common mechanism I have already highlighted, it is antibody dependent, where various organs will be damaged. This is the picture which is being published in New England Journal, where it is being shown that MIS-C cases were more following the peak of COVID events. The similar picture was seen even in India also following first wave and second wave. So we have seen all these cases, high number of cases following say 2 to 6 weeks following the peak of our first and second wave. So more important, as I stressed that before we make a diagnosis, it is important that we need to rule out other conditions. What are other differential diagnoses we need to consider? Very important. Now we are having respiratory infections, so many are there. So we have to rule out all these common conditions before we make a diagnosis of MIS-C. The whether common mimicker are bacterial sepsis, which can mimic like a MIS-C, and Kawasaki, which we need to differentiate this incomplete Kawasaki, which is related to COVID. Then toxic shock syndrome, another common condition which we come across. And as I highlighted, other viral infection which is going on now, we need to rule out by various clinical manifestation as well as probable lab related this thing, and rickettsia and other condition like HLH, MAS and other vasculitis. All these are some of the DDs which we need to keep. But for me, as a general practitioner, if I see the cases, the most important thing I need to rule out is common viral infection, like a dengue, chikungunya, rickettsial infection, which by clinical manifestation, we will be able to make it out. A dengue, now epidemic is going on. They can present with high-grade fever, conjunctivitis, and lab parameters really suggestive of IgM positive. And there will be various fluid like third phase losses will be there. By that, we can make a diagnosis. At time in ICU, we may find difficulty in managing. We'll try to balance that one in the later slide. But majority time, we'll be able to make it out diagnosis. And similarly, rickettsia, the appearance of skin rash, which is very typical in palms and soles, which is typically described that as rickettsia. And more importantly, if you see a scar, the blackish skin rash over the abdomen or face or in the back, you see that itself make a diagnosis of rickettsia. And this is one which is easily treatable using a cheapest drug, doxycycline. So these are conditions which we have to make sure that first we have to rule out. And then we need to consider other DDs like Kawasaki. In Kawasaki, as we see, a majority time they are younger age group, less than 5 years. Whereas MIS-C, we see, of course, almost all age group, but it is generally beyond 5 years we are seeing. So that is one. And more importantly, my MIS-C, as I said, it is cardia and GI, which is the common manifestation they can come, which may not be there in case of the Kawasaki disease. And if you see the inflammatory markers very well elevated in case of MIS-C, not so in case of Kawasaki disease. And more importantly, if you see the CVC, the absolute lymphocyte count is lesser in case of MIS-C, which will be elevated in Kawasaki diseases. And more importantly, it is COVID antibodies which is present in case of MIS-C, not so with the Kawasaki. So this is how we can differentiate one of the common presentation of Kawasaki, we will differentiate with the MIS-C. Then the second common we can see is toxic shock syndrome. Again, the age group is usually in the adolescent age group, and most of the skin manifestation toxic shock is erythroderma or petechiae, whereas here it is like some maculopapular rash which will be there in case of MIS-C. And again, the more important organs is cardia and GI, which is with the MIS-C, not so with the TSS, which you need to keep in mind. Though toxic shock syndrome involves all organs, but predominantly it is renal system and CNS. Whereas here, as I highlighted in MIS-C, it is the cardia and the GI system which is there. And again, inflammatory markers very high in case of MIS-C, not so with the TSS. And antibodies, again, that can differentiate between these two conditions. The one condition which always fit sometimes problem is severe COVID. Because sometimes if they come with the part COVID manifestation, especially if RT-PCR positive, we were in dilemma whether we are dealing with MIS-C or we are dealing with the severe COVID. Again, severe COVID in pediatrics, majority time it is again not like adults where we don't see respiratory symptoms here. Whereas in MIS-C, as I said, these two systems, cardia and GI, which is predominantly affected. And more importantly, the lab investigation, inflammatory markers are quite high in case of MIS-C, not so high with the severe COVID manifestations. This is how we can differentiate between these two conditions. So having been said about the differential diagnosis, it is utmost important what investigations I need to send when I am suspected a multisystem inflammatory syndrome. It is, we have made simpler by saying that as tier 1 investigation, that is basic investigation, and tier 2 were specific to the making a diagnosis of MIS-C. Tier 1 basically to rule out other common condition, wherein we are doing CBSC, CRP and other infection to rule out other common. In tier 2, it is inflammatory markers, then cardiac specific, and then the serology, then related if they are coming with various complications, like we need to send echo, chest x-ray and ultrasound. All these can be done in tier 2. So these are the investigations we have to send. Now, if I have a child with suspected MIS-C, how do I move now? So what monitors, what I have to see, whether he is really going for MIS-C and how I can manage. So important thing is here, we need to monitor both clinically as well as laboratory wise. Clinically, what we look. So look at the fever. As I said, most cardinal feature of MIS-C is fever. It will be continue to be very high grade. Then there will be involvement of two organs, as I mentioned, cardiac and gastrointestine. And to some extent, we may find the skin rash and other thing. Rarely we have to see or look, we have to keep in mind that they can manifest with the neurological manifestation. These are the things clinically we need to monitor the child. Laboratory wise, very important is, as I said, it is CRP, anything more than 40 that you have to consider. And other parameters which are progressively increasing are other inflammatory markers like ferritin, fibrinogen and others, D-dimers. I just wanted to highlight one point about D-dimer is most sensitive. It depends on lab, where they are doing it, how they are doing it. So per se, it is very, very sensitive. It has to be done immediately after taking the blood. If you delay, it will give erroneous result. So you should be very careful when you are analyzing D-dimer values. It has to be analyzed considering the clinical manifestation of the child and not alone D-dimer. Make sure this one. The other parameters we have to look is the blood counts, which will be started decreasing, lipopenia, it indicates CV. And then other renal parameters, which are going to be decreased. So these are the parameters we need to look. So once we have now seen the clinical manifestations, the differential diagnosis and the lab parameters, what we have to look. Now, how we have to manage these children? Okay, so management is, as I said, any child suspected multi-system inflammatory, please admit the child in your hospital, monitor it. And monitoring needs a multidisciplinary approach. That's the most important one. As I mentioned in the earlier slides, that they can present with various organs involvement. Okay, we need to have a various intensivist cardiologist when we are managing these children. They can present with shock, they may have a myocarditis, so sepsis like. So there we need to put all our knowledge in managing these children. So then finally, there is an aspect what we are saying incomplete Kawasaki. There, the important consideration here is this therapy, whatever the incomplete Kawasaki manifestation management using steroid plus IVAG is most important, because this gives a rapid improvement in these children. And it is one of the treatable condition where it can decrease drastically the mortality. That's why we are stressing the point that any child comes with a tropical fever, rule out first common infection, but consider the possibility of MIS-C, because early the diagnosis, then if you start early management, definitely the outcome will be extremely good in these children. So if we have a suspected case of MIS-C, so you send all the tier 1 investigation, including common infections. You have to send. If there is any positivity, then that is positivity in the sense if CRP is more than, though we are saying anything more than 5, but it is more than 40, probably the high chance of MIS-C will be quite high. If this is there, then we have to send the tier 2 investigation, which I have mentioned specifically. So if any child suspected comes to you, then you send initial investigation. If they are having any manifestation in the form of short, multi-organ or Kawasaki phenotype, if this is yes, send investigation, both are positive, consider this as definitely MIS-C. Now you have suspected, but there are no manifestations, like either they are not presented with shock, not in multi-organ, not even Kawasaki. Then you send investigation. Investigations negative, rule out other condition. But investigation suggestive of MIS-C features some, then you again send the 2-tier investigation. If they are positive, then probably we need to make a diagnosis of MIS-C again. So I will highlight again in my next slide. This is the slide which, after lots of discussion in India with our various government agency and Indian Academy of Pediatrics, we made this a very simplified one. We call it as the tropic light management of the MIS-C. Tropic light in the sense it is the red which needs urgent attention. We have to stop, manage it. Then the yellow one, which we have to go slowly, but it has to be managed again. Here, green light, we have to observe. And if required, we have to start the treatment. That's what is there. So once we have a child with the MIS-C suspected, then we have sent the investigation, and investigation also confirmed that it is probably MIS-C. Then there are 3 manifestations they can come. One, they can present with the shock, which we need to manage in this category. They can come without shock, but they will be having the Kawasaki manifestation, which we call it as multi or incomplete Kawasaki. These 2 ways, and we have to manage. The third category is they are having a MIS-C feature, laboratory also confirmed, but somehow they are stable. They are not in shock, they are not in either the Kawasaki manifestation. So these are the 3 ways they can manifest it. So if they are coming in shock and multi-organ involvement, the first therapy is start with methylprednisolone. Dose, again, we have a lot of discussion. So some theories are still there, low to high, but IAP has recommended that start with 10 milligram per kg daily for 3 to 5 days. That has to be given. Along with that, we need to start the IVAG, which is very, very specific, because we have seen that the mechanism involved in manifestation of MIS-C is like a Kawasaki. So we have to give the IVAG. But the problem with us is many times you may not find, or the parents or patients may not be a affordable situation for IVIG. In those situations, the IAP has come out with clear guideline saying for the practicing pediatrician or whoever is practicing outside, they have to document that this is a child with MIS-C and patients or parents are not affordable for IVIG. You need to take a consent and start the only steroid therapy. So that also gives a good result, but make sure that you have to take a consent. That point you have to keep in your mind. So majority time after starting steroid and the IVIG, the improvement is rapid. They will improve within 12 to 24 hours. Clinical signs of improvement will be there. But some children may not improve or not showing any symptoms of improving or recovery. And these children, we call it as treatment failure. This has to be there only after 48 to 72 hours. So if fever is persisting, again worsening of shock, despite these two treatments, still it is worsening, then we can consider it as treatment failure. And we need to consult or refer to a higher center where specialists are available, like a rheumatologist, immunologist, where they can use the biological agent for these cases. But remember, majority, 99.9%, they will respond to your IVIG plus methylprednisolone. So this is how we have to manage shock with multi-organ involvement. If they come with only Kawasaki, but not in shock, then here priority is to give only IVIG first. But again, as I stress here that if you are not having availability or affordability problem, take a consent, start on methylprednisolone. For this phenotype, you can start with a low dose like 1 to 2 milligram instead of 10 milligram, where we can use for the shock management. Here we are using for the Kawasaki management 1 to 2 milligram per kg. So again, wait and watch for 48 to 72. If they are improving, give it for 3 to 5 days, this therapy, and then you have to refer, like manage other supportive care, and they will recover very well. Again, here in this category, after giving say 48 to 72 hours, low dose methylprednisolone, if symptoms are still persisting or worsening, then we consider this as treatment failure, and then we have to increase or step up the dose of methylprednisolone. Instead of giving 1 to 2, we can give 10 to 30 milligram and watch again for the improvement. If they improve, yes, we are giving other supportive care and manage accordingly. If they don't improve, then refer to higher center where, as I said, immunologist or a rheumatologist, where they can use the biological agents for managing these children, we have to consider. But what is my take is this group. This is the most important group where majority of us are seeing this group, right? So this is the group where they are confirmed having clinical manifestation, lab parameter, but they are not either in shock or not in Kawasaki variety, but fever is persisting. Only thing is we need to admit them, monitor them properly. Start with the IV antibiotic as usual with our thinking. There might be some other evidence of infection. So once we get the culture report, we can take it up this antibiotic. But in the present term, we are starting with the ceftriaxone. And then once we have started this one, monitor the child for 48 to 72. Just see for clinical parameters. If they worsen during 48 to 72 hours, either for shock variety, manage them accordingly, or if they go for Kawasaki, manage accordingly. But if they either go for these shock or Kawasaki and still persisting to have a fever only, but no other claim, other parameters are well, child is otherwise stable, then after 48 to 72 hour observation, you can add methylprednisolone in a dose of 1 to 2 milligram. And majority what we have seen in our experience, they do very well with the low dose therapy with 3 to 5 days course. And if they are not improving with this steroid therapy, consider other alternative diagnosis, rule out other alternative diagnosis. That's what, and that's how we need to approach these 3 phenotypes of multisystem inflammatory syndrome. So it is very clear, very simplified by Indian Academia Pediatrics. So this is how we are to manage these MIS-C cases. Apart from this steroids and IVIG, what else we can give? More importantly, it is other supportive care. If child is in shock, give fluid, give inotropes, as is been described by Dr. Karnakar very well. You start with that one, and then you have to look for other things like the cardia is involved. If the LV function is very low, then consider other possible, or is there any evidence of thrombosis? Then we have to consider the antiplatelet therapy. Okay, so like the aspirin, we can start that one like 5 milligram per kg, but only contraindication for this starting of this aspirin is if a platelet is less than 80,000. But more importantly, if there is any evidence of the thrombosis or LV function is less than 35%, then we may have to start before aspirin, we may have to start the low molecular heparin in a dose of 1 milligram per kg subcutaneously for say 7 to 14 days. Though the days are not being described very well in the literature, but this is what we are routinely following in our institute, and most of the IAP guidelines and other guidelines have recommended that 1 to 2 weeks you can give, then you switch to the oral aspirin therapy. That's what we are. So the specific indication for low molecular heparin is if LV function is less than 35%, or if there is any evidence of coronary artery aneurysm or any evidence of thrombosis, then we have to start. These are 3 indications for starting the low molecular heparin. So this is how we are managing all these children with them, and the outcome is extremely good in these children. So once we manage how we can follow up these children, most of the children will do very well, but still we need to follow up these children because there might be a chance that they may go for the arterial dilatation, coronary artery dilatation. For this, we have to follow up these children with the echo at 2 weeks and at 6 weeks. So we are continuing aspirin till 6 weeks. Once we confirm that the coronary artery dilatation is not there, we can stop at 6 weeks. But if there is a persistence of this dilatation, we may have to continue the aspirin for a longer period, probably up to 2 years of this. So this is how we are managing MIS-C cases. So to conclude, the most important issue, what I again stress is that MIS-C is a diagnosis of exclusion. First, you rule out all tropical infections before you make a diagnosis of the multisystem inflammatory syndrome. Once you are confirmed it is MIS-C, this is a multidisciplinary rupture. We need to admit, we need to start systematically in managing these children so that the outcome will be extremely good. The point which I wanted to highlight again is that this is the days where we are seeing after second wave specifically that most of our children are exposed directly or indirectly, and they will be invariably having IgG antibody. Just because they are having IgG or IgM antibodies, don't consider them as MIS-C. And the recent ICMR survey also said almost 70% of our children are being exposed already, and they are showing positivity for the serology. So any evidence of just serology, don't consider. You have to take into consideration whole picture, clinical, laboratory, and all 5 parameters has to be fulfilled before we make a final diagnosis, before we start the therapy for the children. Have this one as a rational therapy, because just because IgG, we have seen in our institute that many children are coming, they're saying that it was positive, so they wanted IVIG therapy. No, that is not the way. So we have to make a complete diagnosis based on clinical picture, laboratory picture, then only we are making that diagnosis. So last most important one is, this is a multidisciplinary approach. We need many like intensivist, cardiologist in managing and giving excellent results in these children. So it has to be a team approach when we are managing these MIS-C children. Thank you. If any questions, then I will be very happy to take.
Thank you, sir. Sir, there was one question whether IVIG and steroid need to be started simultaneously, sir.
Yes, definitely. If you see a shock child, MIS-C in shock or multi-organ, we have to first give the methylprednisolone 10 milligram, because to get the IVIG, it may take time, but immediately arrange and give it if it is possible. If it is not, then as I said, consent is a must before we move on to only with the steroid. So simultaneous treatment with the steroid plus IV is the way we are right now. I don't know in future if there are any requirements, because it is still going rapid changes. But as of now, the IAP and various organizations have recommended that better we go for both combination IVIG plus steroid therapy.
Okay, sir. And Dr. Ratna has asked about the predicted third wave, especially in children, whether this is going to happen or not.
This is $1 million question again. See, the thing is, if you see various theories and other things, everyone thought after first wave we don't have this thing, but suddenly we had such a bad wave which taken out all our theories. Okay, so similarly, though we are hoping that we may not get the third wave, as it is seen in the history also. In India, we are restricted to only 2 waves, but we don't know. We have to prepare for the third wave. And the second question is it purely pediatric, which is less likely to be, frankly, to say that it is again third wave will affect majority adults, but still there might be increase in number of pediatric cases because they are not being exposed very well. But if you see the serology response now, the ICM or whatever publication, again, it says that like adults, they have been already directly or indirectly exposed. So unlikely that it is predominantly child wave. It is a mixed wave only, as we have seen in the first and second wave.
Okay.
Unlikely. We are hoping that we don't get.
Yes, hopefully, yes, sir. Fingers crossed.
Yes.
And Dr. Ratna has asked about the same, sir. Antibody use of antibody cocktail in the children, mild and moderate illness.
No antibody cocktail so far. So they are still in experimental measure. So absolutely, especially in government guidelines, very clear. And even in our IAP, which included the government sector also, we have very clearly said only these 2 drugs has to be used. And any antiviral so far, no clearance for the antiviral for pediatric usage so far.
Okay, thank you, sir. And about vaccination for children.
Yes.
And many other doctors have also asked this previously also, between the Zydus Cadila and also which one is better, the DNA vaccine or the Covaxin, which is coming up.
Yeah, whatever literature if we have come across, most of them are giving similar antibody response. Whichever is available right now, we can take. There is no choice or no comparison that one is better than the other one. But as of now, yes, whatever is available, please go for that vaccination. For children, we are waiting that government has to give the clearance for the 12 to 18 years. We are hoping in next month. If we get, then we can start the vaccination for the children. But less than 10 years, as AC receptors are less only, the infection or severity will be very, very less. They can be taken up in the next issue. But most vulnerable group is 12 to 18, that the government is also interested to take care of these children.
Okay, sir. Thank you, sir. And about the DNA vaccine effect, nothing. No such side effects seen.
Not much. Though there are reports suggesting some cardiac, but so far in India, whatever we are using only 2 so far, both are not causing much problems.
Okay, sir. And Dr. Muhammad has asked about improving the immunity in kids, sir.
Yeah,
how
that
to
is.
improve immunity.
I think whoever has asked, really, it's a good question. That basically our whole idea is that before child is exposed to virus, he should get better immunity. That's because it is all about immune reactions. So better the immunity, better will be the outcome. They may not get even infection chance also. It is most important that we advise diet is the most important one. So all the diet which contains antioxidants should be preferred, especially the vegetables and fruits, which are having highest amount of antioxidant. They should be given appropriately for all children. And more importantly, we have to make sure that the cadre which is going for malnutrition, other thing. We have to supplement these children with all appropriate calories, proteins. Along with that, make sure that they should take all these antioxidant property having fruits and vegetables. That will be the best way we can improve their immunity.
Okay, sir. Thank you, sir. I think that's the end of it, sir. Questions. Thank you so much.
Thank you, ma'am. Thank you.
Thank you, doctor. So for the next part of the session, we will have the quiz based on all the chapters. So doctors, you will now see a poll on the screen and you will get 40 seconds to select the answers. So you will have questions followed with four multiple choice and answer. So please select the right answer. So over to Dr. Gurudat.
Hi, good afternoon, everyone. I'm Dr. Gurudat. I'm one of the pediatric consultants. I really thank the Step 1 for giving me this opportunity. Am I audible?
Yeah, doctor. Yeah, audible.
Yes, sir.
Yeah. So, Shruti, are you going to put the poll for questions?
So, Vishal can, yes, here is the first question, doctor.
Okay.
Are you going to read out the question, doctor?
Yeah, so the first question is choose the true statement. Low flow oxygen delivery devices can provide up to 40% oxygen only. Low flow oxygen devices are those where the flow rate is less than 5 liters, example, nasal cannula or face mask. Low flow oxygen delivery devices are when there is a mixing of room air when the child breathes and hence the variable delivery of oxygen. Low flow oxygen delivery devices are those that provide oxygen FiO2 maximum up to 60%. Okay. Shruti, can you tell me when the time's up for each question?
We will give 40 seconds for each question, doctor, and
Okay, we are done.
we have 10 seconds.
We have 10 seconds for this?
Yes, we have last 10 seconds left for the poll.
Okay.
Okay,
Okay. So what we have is we have 43%. It's a mix of number 2 and number 3 as the answer, but unfortunately the correct answer is number 3. See, what we have to understand is these low flow oxygen delivery devices can provide up to 95% oxygen. It is not just 40%. So the first statement is false. Okay. So the second statement, it says that low flow devices are those where the flow rate is less than 5 liters per minute. So that is not true, because with low flow devices, we can give up to 15 liters per minute, but it is dependent on the variable flow rate because it is dependent on the work of breathing of the patient's flow rate. So a lot of variables come into the play. So it is whether the oxygen delivery system is matching the patient's inspiratory flow rate is what matters. So the oxygen, low flow devices oxygen can go up to 15 liters. So the second statement is also false. The third statement, if you see, low flow oxygen delivery devices are when there is a mixing of room air with child's breathing. Hence, there is a variable. So because it is dependent on the size of the mask, it is dependent on what is the rate of the breathing. It is also dependent on what is the tidal volume, the mask size and everything. So that is why it is a variable delivery of the oxygen. So it is not always fixed. So the third statement is correct. The fourth statement again is false because you can provide up to 95% to 99% oxygen with a NRM mask. So non-rebreathing mask can provide up to 95%. So the fourth statement also is false. So the correct statement is number 3 for this question. Can we move on to the next one? Okay, here we go. 11-month-old baby COVID positive with respiratory rate of 65, saturations of 95% in room air, and BP of 77 to 56, heart rate of 133 per minute. So you get 40 seconds. Okay, so now here the question is clearly telling you that the child is COVID positive and the child has it's an infant because it's less than 12 months old baby, and it has a respiratory rate of 65. So if you remember correctly, respiratory rate of 65 in this age group is very fast. So the child is tachypneic. So if we look at the IAP classification of the mild disease, the moderate disease, the severe disease, and the critical disease, whenever there is any respiratory illness, such as if there is tachypnea, or if there is any saturations which is a little less than 94%, that would be classed as moderate illness. So this child, the answer, which is the disease severity of moderate illness, is the correct answer in this situation. So if the child had what we call as increased work of breathing with retractions, grunting, or if the child had any neurological symptoms such as being very sleepy with COVID or was having seizures, that would be called as severe illness. Whereas in that severe illness group, there will be a subset of children where they will be very critical with shock, ARDS, so they would be critical illness. So as Dr. Vinod sir said, the majority of the children are mild because they don't have any respiratory breathing problems. They do not have. They just have sore throat. They just have some fever. They just have some cough. So that would be mild. If they have any respiratory distress or tachypnea, they would be called as moderate. If they have any increased work of breathing or if the oxygen levels are less than 90%, they would be called severe. So in this situation, the correct answer is number 2. So this child is moderate illness. Okay. Next one, please. So moving to question number 3. So while transporting a child on the ventilator with COVID pneumonia, the following statements are true, except, so you have to choose one answer which is not true. All staff inside the ambulance should be in full PPE. If the child arrests, immediately disconnect from the ventilator and perform CPR. Avoid suctioning in the ambulance. Before returning back, the staff should doff and wear a new PPE after dropping the child to the destination. Your time starts now.
Last 10 seconds left.
Okay, so now the answer here, see, it clearly says that you are transporting the child on a ventilator. So child is already on a ventilator. Now, if you are in a child with COVID, it's very clear that you have to be in full PPE. So the first statement is correct. Okay. So the second statement is the child has a cardiac arrest whilst in the ambulance, which is extremely unfortunate and it's actually very rare. But in that situation, the child is already connected to a ventilator and the lungs are already being supported. Now, if the heart isn't working and the child has a cardiac arrest, there is really no need to disconnect from the ventilator, because what we know is that if the child is on a ventilator, if you disconnect the child, if the child is intubated, when the child is intubated, they release a lot of aerosols. So the virus starts flying all over the place and it puts a lot of risk to everyone around. And if you think about it, if the ventilator is already doing the job of the lung, there is no need to disconnect the child from the ventilator. So just you should start doing the CPR as per the PALS algorithm. So that is the second one, seems to be the most correct answer. Because third one is true, because again, as I said, if you can avoid suctioning the child in the ambulance is very good, because as soon as you disconnect the child from the ventilator, a lot of suctions, the secretions come out, and that releases a lot of aerosols, and that causes a lot of risk to the staff that is sitting in the ambulance. And also, when the child has a pneumonia, if you disconnect them unnecessarily, they may desaturate, they may what we call de-recruit, those problems may happen. So the third one is the true statement. So you should avoid suctioning. Again, the fourth one, when the child has been dropped to another higher center, when you're coming back, it is better we remove the PPE that we were wearing because it is now contaminated, contaminated with all the COVID virus. So it's better to put on a new PPE till the ambulance is fully prepared and then come back to the hospital. So the correct answer here is the number 2 answer is the correct answer, which means that do not disconnect from the ventilator, continue to perform CPR in this situation, mainly because of the worry about release of aerosols in an intubated chair. So that is question 3. Let's move on to question 4, please. Okay, basic ambulance will have all of the following except ventilation, which contains a ventilator mask with oxygen flow meter, nasal prongs, ambu bags, and wood oxygen. Number 2 is circulation, IV cannulas. Number 3 is stretcher trolley with IV stands and transport ventilator. So your time starts now.
Or 10 seconds left.
Yeah. Okay, time's up. So here the question is basic ambulance. Okay, so there is something called basic life support ambulance and advanced life support ambulance. In this situation, the question is saying basic ambulance, which will have everything except the transport ventilator. So the number 4 is the correct answer here, because it will have all the equipment that you require to manage the airway and the breathing. It will also have the equipment to manage the circulation. And there is obviously a stretcher on the trolley with IV stands. So rarely in a basic life support ambulance, there will not be a transport ventilator. So it is better always to choose the correct ambulance depending on the severity and how sick the patient is. If the patient is on a ventilator in your ICU, it's better you always request for a advanced cardiac life support ambulance. So there is a ventilator in that ambulance. So basic ambulance will not have a transport ventilator. Thank you. Next question, please. Okay, so number 5, which of the following statements are true? CRP is a good marker of inflammation in MIS-C. If it is more than 10 mg per deciliter is significant. CRP is non-specific and is only screening tool in MIS-C. IL-6 is a marker of inflammation in children, better than CRP. CRP more than 1 mg per deciliter is significant. Which one is the correct answer? Okay. So now here, see, C-reactive protein is an excellent marker of inflammation. So the correct answer here is that CRP is a good marker of inflammation. So number 1 is the correct answer here. Okay. So do you understand what I'm saying? Because CRP gives you an excellent idea of the ongoing inflammation. So especially if you have a very high number such as 10 mg per deciliter, that is a significant CRP. Now, number 2 is saying that it is non-specific and it is the only screening tool. As Dr. Vinod sir said, there is multiple other parameters that we have to look into, not just the CRP as a screening tool for MIS-C. This is very clearly mentioned in our IAP guideline. IL-6 is a very good marker of inflammation, but it is not better than CRP. I mean, CRP is an excellent surrogate marker of ongoing inflammation. So we don't, in our practice, we don't normally check IL-6 at all because CRP gives us a very good indication. And the last statement is CRP more than 1 mg per deciliter is not very significant. It has to be at least more than 4 or 5 mg per deciliter to be called as significant. So number 1 is the correct answer to this question. Next. So question number 6, with the context of treatment of MIS-C, which statement is true? Which statement is false? Balanced salt solutions have less chloride than normal saline, hence cause less acute kidney injury. As a colloid, we prefer to use hydroxyethyl starch during resuscitation of toxic shock syndrome, toxic shock type presentation. Inotropes like adrenaline can be started in the peripheral line. Adrenaline is preferred over dopamine. So which one is false? This is what Dr. Karunakaran was excellently telling us. "20 more seconds to go." Okay, so here the correct answer here is, as a colloid, we prefer to use hydroxyethyl starch during resuscitation is the correct answer because it is a false statement. See, the first statement here, it says balanced salt solutions have less chloride than normal saline, hence causes less kidney injury. So the chloride content in normal saline is very high, it's 154. Whereas in the plasma, the chloride level is, normal serum chloride level is 110, around 100 to 110. Whereas in the normal saline, it's 154. That's a very high chloride containing solution. So that there is some evidence to say that it causes increased risk of acute kidney injury. So that is correct statement. Second one is saying that we prefer to use hydroxyethyl starch. That is wrong because hydroxyethyl starch was banned about 4 or 5 years ago because of the risk of hydroxyethyl starch causing kidney injury, and also it causes coagulopathy. It makes things worse. So we do not ever use hydroxyethyl starch anymore. So it's banned completely. So that is the second statement, which is false. The third statement, Dr. Karunakaran mentioned very elegantly that adrenaline can be used through a peripheral line. We just have to dilute it correctly. You need to have the nurses, and you need to have these formulas that we regularly use in the ICU to make up these infusions with the dilutions. And also, adrenaline has been shown in randomized controlled trials to be better than dopamine. So the correct answer here is number 2 because it's a false statement. Next question, please. Okay, so number 7, 1-year-old with Kawasaki phenotype MIS-C having high inflammatory markers presents with shock. Echo showed LV dysfunction, 40% function. Heart rate is 155. Saturations are 99%. Respiratory rate is 45. BP is 70 over 55. Child received 10 ml per kg of fluids and has IVC in USG showing fullness. What is the next best thing to do? Your time starts now. Okay, last 10 seconds. Okay, so here, see, the question here is about a child in MIS-C with shock. As soon as there is the word shock is there, we should look at the blood pressure. So the blood pressure is 70 over 55, which is low for this child. And already they have, whenever there is a blood pressure is low, the first response most of the times is to give a small fluid bolus. Especially in MIS-C, as Dr. Vinod sir was saying, some of the children may have LV dysfunction. Some of the children may have what we call vasoplegia, which is as a result of the vasodilatation because of the vasculitis that these children have. So in this situation, if you see the child has a good diastolic, whereas the systolic blood pressure is low because the LV dysfunction is, a left ventricular dysfunction is there. In that situation, the correct answer is whatever you have all mentioned, which is the number 2 answer, which is start adrenaline at 0.1 mcg micrograms per kg per minute. So do not give noradrenaline here. Definitely not dopamine and dobutamine in this situation. So adrenaline is the correct answer here, number 2. Thank you. Next question, please. Next. Number 8, when do we do a CT scan, CT chest for children with COVID? Number 1 option, CT chest is essential in classification of severity of illness, hence we do it in all children. CT done only when there is an oxygen requirement in the child or there is a diagnostic dilemma. CT chest is done in all children about 12 years of age as they behave as adults. Whenever the chest X-ray is abnormal, the CT chest needs to be done. Your time starts now. Last 10 seconds. Okay, so here the correct answer here is that CT is only done when there is oxygen requirement in the child. See, in an adult COVID, they tend to do CT in most of the patients with COVID. Okay, whereas in children, the chances of having COVID pneumonia is very less, and CT scan itself is a lot of radiation to children. We say CT scan can be up to, at least 100 chest X-rays. So it's so much radiation that it is equivalent to taking 100 chest X-rays. So in that situation, we would only use it if the child has got oxygen requirement, because we want to classify how bad the COVID pneumonia or COVID-induced ARDS is. So first statement here is CT chest is essential in classification of severity of illness. No, we do not need CT chest. We just need to clinically examine the child, look at their vital parameters, including the respiratory rate, heart rate, blood pressure, and their saturations. So the next statement is the correct one, which is CT is only done when there is oxygen requirement in the child or there is a diagnostic dilemma. Number 3rd statement is CT chest done in all children above 12 years. No, we do not. We only do it if there is oxygen requirement, regardless of the age of the child. And the 4th statement is whenever the chest X-ray is abnormal, CT chest needs to be done. That is not true either. If the chest X-ray is abnormal and the child is requiring oxygen to maintain their saturations, then we would do a CT scan. So number 2 is the correct answer in this question. Thank you. Yeah, majority have answered that. Yeah. So number 9, choose the false statement here. HFNC also means high flow nasal cannula reduce the need to intubate when children have mild to moderate respiratory distress and hypoxia. After starting HFNC, we know it is working when the respiratory rate and the heart rate reduces in 2 hours. Children on HFNC should not be pruned as it occludes the airway. Better to manage the baby in negative pressure room when on HFNC. Your time starts now. Last 10 seconds. Okay. So now see here, we have to choose the false statement. So the correct answer here is number 3, which is children on HFNC should not be prone as it occludes the airway. Now, proning does not occlude the airway. So we are very much allowed to prone them, because awake proning, meaning the patient is awake and you ask him to lie on their belly, is actually shown to be beneficial in patients with COVID. So the number 3 is the false statement. I'll tell you why. Number 1, high flow nasal cannula does reduce the need to intubate when children have mild to moderate respiratory distress. So that is true, because that has been shown across the board in many of the studies. After starting HFNC, we know it is working when the respiratory rate and the heart rate reduces in 2 hours. So that is also true. The respiratory rate and the heart rate takes about 2 hours to reduce. And that is when you know that it is working. And the 4th statement is better to manage the baby in a negative pressure room. So we know that very rarely when the child is on high flow nasal cannula therapy, the aerosols can come out of the virus aerosols. So in that situation, it's better to have a negative pressure room. So the correct answer here, which is children on HFNC should not be prone, because they can be prone and it does not occlude the airway. Okay. So I think 63% have got it right. So next question, what is the best modality of assessment for cardiac dysfunction in children with MIS-C? Your time starts now. Echo is the gold standard. Echo may be normal, hence we look at cardiac biomarkers like proBNP, CKMB, ECG. Okay, last 10 seconds. Okay, so now here the best modality of assessment of the cardiac dysfunction. See, the number 2, which is 43% have got it right, which is the correct answer. Echo may be normal, hence we look at cardiac biomarkers like proBNP and TROPA is the correct answer, because sometimes the echo may be normal. That doesn't mean that the child doesn't have cardiac involvement. And ECG, lot of the times it's normal, and CPKMB actually is not very useful at all. So number 2, where you do an echo and be sure that there is no cardiac dysfunction, and also you check for what we call as cardiac enzymes. Those enzymes could include what we call NT-proBNP and TROPI. So whenever there is a child with suspected MIS-C, in our unit, we always say, do an ECG, echo, this blood test for what is called a NT-proBNP and a TROPI. So number 2 is the correct answer here. Thank you.
The last question, Doctor.
Okay, so last question. When a child presents with shock, what is the right statement? Initial fluid bolus is 30 ml per kg of normal saline. Balanced salt solution like plasmolite or cabalite have less chloride content compared to normal saline, hence cause less acidosis. Fluid boluses need to be repeated up to 60 ml per kg, hence then choose inotropes if not improving. DNS is isotonic fluid, can be used for resuscitation. Your time starts now. Last 10 seconds. Okay. Time up. So here, see, when the child presents in shock, we are mainly talking about, MIS-C or a septic shock. In this situation, the correct answer here is number 2, because as I said earlier, because the chloride content is less, the chances of it causing kidney problems is less. So number 2 is the correct answer. 33% got it right. First statement says initial fluid bolus is 30 ml per kg of normal saline. 30 ml per kg is a lot of fluid to give to a child, at one go. So we usually say give 10 ml per kg, or sometimes very rarely in a septic shock, we may give 20 ml per kg of normal saline. Because what we have to remember, these fluids are drugs in their own right. So every drug has a side effect, a good effect and a bad effect. So we want to give the drug and reassess the child. So first statement is not correct. Coming to the third statement, we now say fluid boluses can be repeated only up to about 40 ml per kg, and after that we should be thinking about moving on to inotropes. So there is a lot of actually now focus about not fixing to 30, 40, 60 or anything. If you give a fluid bolus and there is no response and there is no improvement in the heart rate and the blood pressure, then we move on to what we call early inotropes. So the third statement also is not correct. So we do not give up to 60. And the fourth one, DNS is dextrose normal saline. It is slightly hypertonic and it is very hyperosmolar also. So we do not use that for resuscitation. So number 2 is the correct answer in this situation. 33% got it right. Thank you.
Doctor, there is a message from Dr. Balachandra. In question 7, he did not prefer Dr. Domain. So can you please explain once again?
Question 7 was which one? Can you just go?
Yeah.
So here, what I was saying was we have a 1-year-old child with what we call Kawasaki phenotype. So the child has some mucocutaneous changes. It also has high inflammatory markers. So the child clearly has MIS-C. And also child has cardiac dysfunction with left ventricular dysfunction. And if you see the blood pressure here, child is clearly tachycardic, and the blood pressure, the systolic is low, because for a 1-year-old, we expect the systolic to be at least about 75, 80, So in that situation, when the systolic is on the lower side and already there is a LV dysfunction, it is better to improve the LV. And we know that adrenaline at a low dose has a very good beta effect rather than any other drugs that is there. And so that is why adrenaline is the correct answer here. Because the child has already received some fluid bolus, and when somebody has done an ultrasound scan to look at the inferior vena cava, it is already showing full. So there is no need to give any further fluid boluses. We have to move on to the inotrope in the situation. And the best one here is not noradrenaline, because noradrenaline makes your diastolic blood pressure increase more. But if you see in this child, the diastolic is already high. So that's why adrenaline is better in this situation. Does that make sense?
Yes, doctor. Thank you so much for answering the question.
Thank you, doctor. So
thank you.
So before we close this session, I request you all to click the link that I have posted in the chat box. Yeah, I've posted in the chat box, and type thank you in the comment section as a thank you gesture to our wonderful faculty.
I would like to thank all the faculties who did this session, from Dr. Baswaraj, Dr. Lalita, Dr. Santosh Sohans, Dr. Sridhar, Dr. Vinod, Dr. Rakshay, Dr. Karunakar, Dr. Raghunath, Dr. Chinnappa, Dr. Supraja Chandrasekhar, and Dr. Gurudat, who at the last moment wonderfully agreed, and did this wonderful session for us. He conducted this quiz. Thank you so much, doctor, for taking time off your busy schedule and coming here and doing this quiz for us. We have received appreciations from everybody, the way that you have explained it. We have also received some personal notes thanking you. So thank you so much for doing this. Please do click on the link posted in the chat box and say thank you to all the wonderful faculties, because this is our last day of the session. With this note, I would also like to mention that we will be coming up with an advanced course in the next week or the week after. So please do stay tuned, and we will come up with one more course which will be a little advanced. Thank you, everyone. Thank you so much, Dr. Gurudat.
Thank you so much. Thank you. All the best.
Thank you, doctor. So we will keep this going for another 10 minutes, 5 to 10 minutes. Please do click on the link and comment thank you in the link that has been provided, because all our faculties will be watching us live on Facebook as well. Thank you so much. We see a lot of comments popping up in the Facebook post that we have posted. Thank you so much for. Just to mention, the recorded link along with your certificates will reach you soon in a week's time. Thank you, Arjun, for moderating this session, and Vishal for technically handling the entire thing. Thank you so much.
Thank you, Shruti.
Thank you to all the wonderful doctors who attended this session and who are helping us curb the third wave. You can also volunteer at Project Step 1 by logging into www.projectstep1.org. Thank you, everyone. Have a great day.